Hello and welcome to the introduction to middle ear implants. My name is Isabel Gehring. I'm working as clinical support specialist for the business unit Vibrant, and I will now give you an overview about middle ear implants. I will compare different devices, and I later on will talk about the Vibrant Sound Bridge. So the first treatment option is not using active implants but to use passive implants, and this passive middle ear implants reconstruct the disrupted or fixed ossicular chain. So they are closing the air bone gap. As you can see here on the picture, there are different versions available. So whenever the ossicular chain is not intact, for example the incus is missing, you could treat this with a PORP. Additionally, treatment option is to use a TORP, which is a total ossicular replacement prosthesis. Surgeons usually present audiological results to demonstrate the success or the failure of these prostheses. The air bone gap is often persisting with a success rate of less than 50% immediately after surgery, which is for sure a disadvantage. When we are talking about active middle ear implants, then these are devices that are surgically implanted in the middle ear. They are stimulating the ossicular chain or the inner ear, and usually do not obstruct the external auditory canal, which is a big advantage compared to conventional hearing aids. They have basic components, so there's a microphone, an audio processor, for sure a battery, energy supply is needed, there's a receptor and a vibration transducer. These devices can be piezoelectric or electromagnetic, and I will explain in a few minutes what the difference is. This active middle ear implants are especially for patients who do not benefit from conventional or conservative therapies, including an optimally fitted hearing aid. For sure, these active middle ear implants are not indicated for patients with profound hearing loss, so in these cases other treatment options need to be considered. When we're talking about the history of active middle ear implants, it's quite impressive that up to the 1990s, amplification devices for hearing impaired people who had a sensory neural but also a mixed or conductive hearing loss were really limited to conventional hearing aids. The history started quite early in 1935 with the Wilska experiment with iron particles. In this experiment, Wilska placed iron particles directly on the tympanic membrane, creating a magnetic field to stimulate the ossicles. The magnetic field was generated by an electromagnetic coil inside the headphone, as you can see on the picture, and this then caused the iron particles to vibrate in synchrony with the magnetic field, which in the end caused vibration or produced vibration of the tympanic membrane and stimulated hearing. In 1959, Rutschmann glued magnets to the malleus umbo, causing also here a vibration by applying a modified magnetic field with an external electromagnetic coil. This again resulted in vibration of the ossicles and produced a hearing sensation. In the 1970s then, devices were the first time placed really into the middle ear, and the first one who did this approach was Frederickson and colleagues, who developed the first mechanical device at the Washington University in St. Louis. In 1984, the Ryan, which is a partially implantable device that was developed at 2 universities in Japan, was implanted. This middle ear device uses a piezoelectric transducer, and clinical trials were followed quite long periods, so over 10 years, where this device was implanted in more than 80 patients. However, the results were really mixed, and over time the piezoelectric element of the transducer often failed, and eventually the project was then abandoned. Heide and others in 1988 proposed another system, so not an piezoelectric but an electromagnetic system, and this was consisting of a small magnet that was glued on the eardrum at the level of the malleus, and they suggested that the mean functional gain of their devices is 10 decibel higher than the patient's own conventional hearing aid. Unfortunately, there was no improvement in speech recognition at 65 decibel SPL, suggesting that also the device could amplify it quite substantially. It was not able to amplify sounds at normal conversation level. In 1993, then Jeffrey Ball got the patent for the first electromagnetic floating mass transducer. And this device, the Vibrant Sound Bridge, later on was the first middle ear implant to be approved by the FDA. So what are now the devices that are currently on the market? When we're talking about active middle ear implants, they are all transcutaneous. This means the skin is left intact. You can differentiate between fully implantable devices as the Esteem produced by Envoy or the Carina produced by Cochlear. But there are also partially implantable devices, and the Carina is also considered as partially implantable, as there is a button audio processor that might be used additionally. So partially implantable always means that there's an implant inside under the skin and an outside device like an audio processor worn on the head. There's the Codax made by Cochlear. There's the MED, also made by Cochlear, but those two devices, at least here in Europe, are at the moment no longer available. Additionally, there's the Maxum device produced by Ottotronics, and there's the Vibrant Sound Bridge produced by MED. When we are assessing these middle ear implants, there are some factors we need to consider or need to discuss. So we need to talk about candidacy, technology, surgical flexibility, and how the implant is attached to the ossicular chain. Children is a really important topic, so can kids be treated, and also how the device, the external part of the device looks, is for sure interesting for you. When we are assessing candidacy, these implants, the middle ear implants, can treat conductive hearing loss, mixed hearing loss, and sensorineural hearing loss. When we go more into detail, then the Esteem is able to treat moderate to severe sensorineural hearing loss. What is really important to consider is that implantation of the Esteem leads to a mixed hearing loss, and I will later talk about this. Carina implant can treat moderate to severe sensorineural hearing loss, but also conductive and mixed. With the Maxum implant, we can treat moderate to severe sensorineural hearing loss, and with the Vibrant Sound Bridge, we can treat mild to severe sensorineural hearing loss, but also conductive and mixed hearing loss. What technology lies now behind the different implants? So as I already mentioned, there are devices which function due to an electromagnetic field. So the system consists of a magnet and an energizing coil. The magnet is then attached to the ossicular chain or to the tympanic membrane or the inner ear, so the round window. And a fluctuating magnetic field is generated when the coil is energized, and this is due to a signal, such an acoustic input. The external microphone of the device sends the signal through an inductive coil, and this is creating the magnetic field. The implanted part has a receiving coil which is picking up the signal and is transmitting it to the transducer that is attached to the ossicles or to the inner ear. The transducer then vibrates in synchrony with the magnetic field that is produced from the outside. How about piezoelectric systems? Here the device uses a piezoelectric crystal, and this crystal has the property to bend and to generate an electric charge when an electric charge is applied to it. So the crystal has two functions. On the one side, it can function as a microphone, generating electric charge in response to incoming sound waves, which bend then the crystal. And it can function as a driver, so when it is attached to the middle ear bones, and in this way it is moving in response to the electric charge from the microphone. This in the end causes then the middle ear bones to vibrate and transduces sound to the inner ear. But how is this now? These two systems, how are they used in the devices that are on the market at the moment? So for the Carina, it's an electromagnetic system. This is also true for the Maxum. The Esteem, it's a piezoelectric system, and it's the only piezoelectric middle ear implant on the market. So this means that the vibrant sound bridge, it's also function via electromagnetics. What about surgical flexibility? So when we are talking about surgical flexibility, for the Carina, you see the transducer, which is called actuator, is placed to the incus, to the long process of the incus. When we're talking about the Maxum, you see this electromagnet, the small electromagnet is placed to the head of the stapes. With the Esteem, the transducer is placed to the head of the stapes or to the footplate of the stapes, and additionally the microphone is in contact with the malleus. So here you really need to disconnect the ossicular chain to have a working system, because if you consider that the microphone picks up the sound from the ossicle, which is, I think, a quite interesting idea, but on the other side the amplification takes place at the stapes. You need to separate those two structures in order to avoid feedback. For the vibrant sound bridge, we can put the FMT, the floating mass transducer, to different middle ear structures, and we are really flexible when it comes to placing the system. And I will let you know more about this later. So again, the attachment. When we're talking about the Esteem, you see, or I already mentioned, that we have multiple attachment points. So on the one side we have the microphone or the sender, and on the other side we have the transducer. So we have 2 points of attachment. For the Carina, we again have multiple attachment points. So on the one side the microphone needs to be placed somewhere under the skin, and the actuator needs to be placed at the head of the stapes or onto the stapes. When we're talking about the Maxum, we are having single point attachment in this device, so the magnet is only attached to the head of the stapes. And with the vibrant sound bridge, we are also just having 1 point of fixation. Why is this important? This is important when treating kids, because in children the skull is still growing. This means whenever you have 2 points of fixation, the system cannot be used in kids. What does it mean for the different implant systems that are available? So with the Esteem, we have the 2 points of fixation. This means it's not suitable for kids. With the Carina, it has the approval from 14 years and above. Maxum, not suitable for kids. and the Vibrant Sound Bridge. It's suitable, especially the Warp 502, it's suitable from 3 years and above because we have just this one point of fixation. What about the appearance? So how do the systems look, and how do the users look that are wearing the system? One thing that needs to be mentioned for the Esteem, this is a fully implantable system, so also the battery is implanted. That means there's no device that is worn on the outside, which for sure is an advantage, but this also brings disadvantages because with other devices you have the battery in the outer part, in the audio processor, and that means for the user that he's just opening the battery door whenever he wants like to exchange the battery. For a fully implantable system, once the battery lifetime is over, the user needs to undergo additional surgery to get a new battery, and the system needs to be exchanged. For the Carina, this is in general also a fully implantable system, so the microphone is placed under the skin, but in this, as the microphone is placed under the skin, a lot of feedback is generated. So whenever the user turns his or her head, this might lead to feedback, and especially in demanding listening situations or when the hearing level is a little bit more down, an additional audio processor is required. So the button AP is required, which can be seen on this picture. This was the only picture where I found where you really can see the audio processor, even if it's almost invisible on this picture. With the Maxum, the concept is a little bit a different one. So here we have the external part not as a button processor on the head, but it is inserted into the external auditory canal, so we occlude the ear canal in this using this device. With the Vibrant Sound Bridge, you see we have here the button processor that is placed on the skin. So what about the Vibrant Sound Bridge now in more detail? What is the level of intervention? And this I already mentioned. We are talking here about an active middle ear implant that is placed on different structures of the middle ear. When we're talking about the history, I already mentioned that Jeffrey Ball was the inventor of the system. He's not only the inventor, but also he is a bilateral sound bridge user. When he was a child, he suffered from a severe infection that was treated with antibiotic medication, and this led to an ototoxic effect, and he from that on had a sensory neural hearing loss. He never liked to use conventional hearing aids, and he really felt that there's the need to create something new. So in 1993 he filed the first patent of the electromagnetic transducer that can be seen on this picture, the FMT, floating mass transducer. In 1996, finally the first patient was implanted by Dr. Fisch in Switzerland, and 2 years later the CE mark was given to us in Europe. In 2000, the FDA approval for the USA for treatment of sensory neural hearing loss was given, and in 2003 the Vibrant Med-El hearing technology company was found here at Med-El. In 2007 we got the approval for treatment of conductive and mixed hearing losses, and this was definitely a very big step for people or for candidates, because this people who have a mixed hearing loss up to then did not have a proper treatment option. In 2009 we got then the approval for treating kids in Europe. In 2010 you see that a range of vibroplastic couplers was approved in Europe, and I will go into detail this later. In 2014 then the new Vibrant Sound Bridge system, the Warp 503, and the new audio processor, the Samba, came to the market, and there was also a range of new couplers approved. Last year we had the honor to celebrate 20 years of Vibrant Sound Bridge. Today the Vibrant Sound Bridge is therefore implanted for 20 years. We have more than thousands of patients. It's the most successful middle ear implant and it has market approval in all major markets. It's implanted in over 500 clinics worldwide. How does the sound bridge work? And this is a short video I would like to show to you.
The Vibrant Sound Bridge is a middle ear implant hearing system recommended for individuals with either a moderate to severe sensory neural hearing loss or a mixed or conductive hearing loss. The Vibrant Sound Bridge is an alternative to conventional hearing aids or bone conduction devices. The Vibrant Sound Bridge middle ear implant system consists of an externally worn audio processor and an implant which is placed surgically under the skin. The audio processor is held in place by magnetic energy and can be worn comfortably under or over the hair. Sounds are picked up by the microphone in the audio processor. The audio processor converts environmental sounds into electrical signals. The electrical signals are transmitted through the skin to the implant. The implant relays the signals down the conductor link to the floating mass transducer, abbreviated FMT. The FMT converts signals into mechanical vibrations, which set the structures of the middle ear into motion. The FMT has a frequency range of up to 8,000 Hz. The versatility of the FMT has led to a variety of surgical applications known as vibroplasty. The incus vibroplasty, for example, involves affixing an FMT to the incus. This procedure is a treatment for sensory neural hearing loss. In round window vibroplasty, the FMT is placed on the round window for treatment of conductive and mixed hearing loss. The FMT can also be placed on different structures of the middle and inner ear in order to stimulate these structures to move. Mechanical vibrations can be controlled to be slower or faster depending on the particular type of hearing loss. The FMT transfers vibrations to the inner ear and onto the brain where these signals are perceived as sound. The success of the Vibrant Sound Bridge as a treatment for hearing problems originating in the middle ear can be traced to its unique design. Use of the FMT is independent of skull growth because the FMT need only be affixed to the structure which it stimulates. It's therefore an optimal solution for both children and adults. The audio processor of the Vibrant Sound Bridge offers users the state-of-the-art in hearing technology, including intelligent signal processing, natural sound quality for both speech and music, dual microphones, as well as an improved signal range and a selection of various listening programs. Because the audio processor is an external component, it can be replaced with a newer model as technology improves. This is one of the distinct advantages of the partially implantable system. After a simple fitting, long-time users are able to take advantage of the newest technological improvements years after receiving their first implant.
So the general system composes two parts, the implantable one and the outside worn audio processor. Here on this picture you see the Warp 502. Warp stands for Vibrating Ossicular Procedures. It is composed of a magnet and coil, the demodulator that is transferring the signal to the conductor link, and the hard piece of the implant, which is the floating mass transducer, the FMT. The newer system, the Warp 503, in general is very similar. The only difference you can note is that it has wings for fixing the implant. And another thing, a small change we made, is that the floating mass transducer no longer has this clip, so the attachment clip, but it comes without clip to have even a greater surgical flexibility. And we are using, together with the Warp 503, the Samba audio processor. But this audio processor can also be used with the old system for sure. When I mentioned surgical flexibility, I definitely need to mention the couplers. So we are having different couplers to treat different kind of hearing losses. On this picture here you see to the very left the short process coupler and the long process coupler to treat sensory neural hearing loss. So those couplers go onto the intact ossicular chain. Clip coupler goes onto the head of the stapes. The oval window coupler is stimulating the oval window whenever there's no stapes present, and we have two couplers for directly stimulating the round window. I already mentioned that the Vibrant Sound Bridge has single point attachment, so only the FMT is attached to one single middle ear structure without any attachment to the skull. So this means it's independent from skull growth and it's suitable for implantation in kids, and it also has an easier surgery. When we're talking about indication criteria, we can treat mixed hearing losses, for example after middle ear surgery, for example after cholesteatoma removal, and conductive hearing losses, so in case of atresia, for example. In these cases, bone conduction values need to be better than 45 decibel in the low frequencies and better than 65 decibels in the high frequencies. So when treating conductive and mixed hearing loss, we are having two options to placing the FMT. On the one side using the clip coupler, and on the other side using the round window soft coupler or the tightened round window coupler. The clip coupler is used to position the FMT on the head of the stapes whenever the stapes is present and robust. This is really important that the stapes is robust, and you might also not use the clip coupler, but could also use the clip of the FMT from the Warp 502. What is important is that the clip is bent or is properly fixed onto the stapes and stabilized towards the tympanic membrane, so you might use some cartilage in between the tympanic membrane and the FMT to ensure that the system is stable. When we are talking about coupling or stimulating the round window niche, in cases the ossicles are all gone and there's no stapes present, we are using the round window soft coupler or the round window tightened coupler that you can see over here. So both options allow a positioning of the FMT in the round window niche, and in this way you're quite away from pathology because you're in this defined space of the round window niche. What about the audio processor, the externally worn processor? This is the MAD. It has a dual microphone option and digital signal processing. It offers a wide frequency range. Battery life is up to 6 to 7 days. You see over here the choice of colors. So it's available in 4 colors, and what is important is that we offer 5 different magnet strengths to keep the audio processor nicely in place over the implant without any pressure. The system is very cosmetically appealing as the audio processor can be discreetly worn under the hair. The implant is invisible under this intact skin. There's no permanent wound care, and this means that there's very little risk of skin irritation, also because we can change and reduce the magnet strength if needed. This all sums up to fewer medical complications. What are now in a very summarized way the advantages of the Vibrant Sound Bridge? So it's a transcutaneous device offering a very nice cosmetically appearance. It is very flexible in terms of surgery. We can stimulate over a wide frequency range. It's suitable for kids, but for sure also for older people. There's no feedback because the microphones and the internal FMT are separated. And it's compatible with the newest technology, so you always can upgrade the audio processor to a new available version. Yeah, and with this I would like to thank you for your attention and have a nice day.